Welcome everyone to Health for the World International Grand Rounds. We are honored to have our Grand Rounds speaker today. Our Grand Round speaker is Dr. Duong, who is from University of Utah. She received her medical degree from the University of Pennsylvania and has done residency and fellowship at University of Pittsburgh. Above all, she's a world leader in radiation dose reduction in CT and quality improvement in radiology and is a champion in radiology. She's a part of the cardiothoracic imaging section at University of Utah and is also a part of the University of Utah Health for the World chapter. We are really honored to have such a wonderful and renowned speaker for our grand rounds today. Dr. Duong will be talking about micronodules. We also have Dr. Nick Wyan today, who will be helping us with moderation, and we'll meet you after the grand rounds. We have Claude here, who leads our Benin chapter in Africa, and will be also helping with the moderation. So thank you everyone for joining, and I will let Dr. Duong take over.
Thank you for that kind introduction. I'm honored to be here, and I would like to speak to you today about pulmonary micronodules. It's Micronodules are small nodules that we see on diffuse lung disease, and they can be a little bit challenging sometimes and daunting to look at and figure out the diagnosis. So my approach is to start with the normal lung anatomy, and that the reason for that is that if you understand the secondary pulmonary lobule well, you can figure out what micronodular disease is occurring. So I'm going to spend a lot of time talking about the lung anatomy. And it looks like there's some things in the chat, so I just wanted, let me just check real quick to see if I'm having any trouble. Okay. Thank you for the welcome. Yes, so we're going to talk about the lung anatomy. Let me see here. Oops. And spend a lot of time talking about the secondary pulmonary lobule, because understanding the secondary pulmonary lobule will help you understand the patterns of micronodular disease. Then we're going to go over an algorithm that I use for diagnosis, and then I have several interactive cases that you can use what I taught you and figure out some cases on your own. So first, I wanted to acknowledge my mentor and good friend, Dr. Carl Furman, who recently passed away this summer. He was a wonderful teacher, and one of the things that he taught me was how his gift when he's teaching chest radiology was to start with the anatomy and the physiology and really bring together those concepts into radiology. And I hope to do his slides justice today, because he gave me some of his slides that he used for teaching. So the secondary pulmonary lobule is an important anatomic unit to understand when you're doing high resolution CT and looking at diffuse lung disease. And as I was putting together these slides, I realized that the lung is a fractal, that it has larger parts that are recapitulated in the smaller parts of the lung. And so I got really excited about thinking about this, and I was telling my son, I think the lung is a fractal because there are smaller parts that are similar to the larger parts. And he said, no, it doesn't infinitely, the similarities don't go on infinitely, so it's a self-similar fractal-like. And the reason I say that it's a fractal is because the lung is supported by the interstitium. The interstitium is a scaffolding that holds up the different parts of the lung. And the overall lung anatomy, there is interstitium in the periphery of the lung that makes up the subpleural lung and the pleura. And the interstitium also is in the interlobular, or forms the interlobular septa, where the lymphatics and venules live in the lung. Also, the interstitium is in the axial part of the lung, around the bronchovascular bundles, which contain the arteries, the bronchi, and again, the lymphatics. So a secondary pulmonary lobule is the smallest unit of lung that is separated by connective tissue entirely. And the lobules are of variable sizes and shapes because they're made of anywhere from 3 to 24 acini. And an acinus is the unit of lung that is the unit of lung that's distal to the terminal bronchiole. And as you can see on this lung surface, there are all these polygonal shapes, and each one of these is a secondary pulmonary lobule. And as you can see that there are various sizes and shapes. So here's a CT scan showing the secondary pulmonary lobule very well because this patient has pulmonary edema and there's fluid in the septa. And so you can see these septal thickening here, all these little lines. These are the curly lines that we see on chest radiograph. And as you notice, again, there's different sizes and shapes. And at the center of some of these secondary pulmonary lobules, you can see a little dot, and that dot is the arteriole. Also, you notice that in the center of these lobules, there's some lobules that have a little bit of ground glass, and this is the fluid that has spilled out into the alveoli. So the anatomy of the secondary pulmonary lobule is very similar to the anatomy of the lung overall. There's peripheral interstitium, and then there's axial interstitium that contains these other structures. So in the periphery, there's interstitium, there's lymphatics, this is the green right here, and there's also the pulmonary venule, which is the veins that are carrying away the oxygenated blood back towards the heart. In the center of the pulmonary lobule, you have the central dot, which is the arteriole. There, of course, is the interstitium and the lymphatics. And then there's also the airway that extends from the center of the pulmonary lobule. So I have some questions for you. And the first question I have is, what are the two structures that are both in the axial and the periphery of the lung and the secondary pulmonary lobule? And I would like you to type that into the chat box. Oops. Well, I kind of gave it away anyway. So, sorry, having trouble with this since the chat box won't show up. But yes, so the
Rajesh said lymphatics. He typed in lymphatics.
Yes, great. Lymphatics, yes, and then the interstitium, of course. So the interstitium and the lymphatics are the two structures that are both in the axial and the periphery of the secondary pulmonary lobule. Okay, so now that you understand the secondary pulmonary lobule, I hope to show you that these patterns of micronodular disease really makes sense in the context of the secondary pulmonary lobule. So you might have a randomly distributed nodules, and this can be anywhere in the pulmonary lobule. So you'll see them on the fissures, you'll see them just randomly distributed throughout the lung. Some of them will be around the bronchovascular bundles. It's as if you took some grains of rice and threw it onto the lung, and it lands anywhere it wants to go. Now, if you have an interstitial or perilymphatic pattern, then you'll see nodules along the pleura and the subpleural lung. You'll see nodules along the bronchovascular bundles because of the axial lymphatics and interstitium. And sometimes you'll see nodules along the septa, which also contain lymphatics and interstitium. And then finally, you have the centrilobular pattern, which is, again, the center of the pulmonary lobule. And these are somewhat easy to spot because they are fairly evenly spaced, and they're not going to be on the pleura or subpleural lung. And as you can see here, there's a little space between the pleura and subpleural lung and these nodules. And you'll
Sorry,
also see
Dr.
them.
Duong. Sorry, Dr. Duong. I think your presentation is frozen on the question page.
Okay. Let me see. Can you see it now?
Yes.
Okay. On the nodules?
Yes, it's on the nodule slide.
Okay, good. It's on the nodule slide. So should I go over that? Let me go over that again. So I was talking about random nodules, which can be anywhere in the secondary pulmonary lobule. So they will be either on the septa, they will be in the pleura, and then they're also just randomly distributed in the secondary pulmonary lobules. So they'll just be as if you threw down some rocks or some grains of rice and they just went anywhere. The interstitial perilymphatic pattern, you will have nodules on the pleural surface, in the subpleural lung, and also along the bronchovascular bundles at the and sometimes along the septa as well. So they're clustered in areas, but and not randomly distributed. And then you have the centrilobular pattern, which is going to be at the center of the pulmonary lobule, and there's going to be some spacing between these nodules that is fairly regular. And they will also be at the ends of the vessels and the bronchovascular bundles. So you'll see them fairly evenly spaced, and there will be some, and they won't be on the pleura or subpleural lung. So you will sometimes see a little black line along the pleural surface where there won't be any nodules. Okay, so one thing that can really help you when you're looking at micronodules is to use a maximum intensity projection image. And this takes the most dense pixels and accentuates them. So if you do a thin slice maximum intensity projection, you may see that there are a few nodules, or maybe they're vessels. They're difficult to tell on a thin section. You want to do a thicker section, and when you get to around 7 or 8 millimeters maximum intensity projection, you really start to see these nodules very well. And not only that, but it can help you figure out where these nodules are, because you can see what their relationship is to the vascular structures and to the fissures and the pleura better. So that can really help you decide what nodular pattern you have. So let's start with the centrilobular nodules. What structures are in the central parts of the secondary pulmonary lobule? Well, you have airway, you have arterioles, and you have lymphatics and interstitium. So if you have nodules that are related to the airways, they are often in a tree and bud pattern, which is bronchiolar impaction of the distal bronchi. So they look like a tree that is in bud in the spring. Or you may have more fuzzy indistinct nodules as the process extends into the acini from the airway. So things that arise from the arterioles, these nodules tend to be more discrete, meaning that they're better defined. You may also see some beading of the vessels if it involves the larger vessels as well. And then for the lymphatics and interstitium, these are also discrete nodules. And remember, because we have lymphatics and interstitium in the center of the lobule as well. You'll see those there, but also you should see nodules in the peripheral interstitium. And in contradistinction to these other two processes, which should be only centrilobular. Okay, so to determine where these nodules are, the first thing I do is I look to see if there are any nodules along the pleura or the fissures. And if there are, then that goes down a different pathway where you're looking to see if the nodules are randomly distributed or if they're clustered. But if they're not, you have to ask yourself, are these nodules only in the centrilobular lung? So again, you know, a lot of the centrilobular nodules that we see are airways in origin, and this may be due to mucus impaction in the bronchi, and this is typically due to infection. And the infection that we most commonly associated with a tree and bud pattern is tuberculosis, although, or at least it was first described in tuberculosis, but we are really seeing this pattern with all different kinds of infection, including viral and bacterial infections. You can also see with in an airway pattern, softer, fuzzy looking nodules, more indistinct nodules in the center of the lobule. And these are most often due to subacute hypersensitivity pneumonitis, although respiratory bronchiolitis, which is a disease that you see in smokers, can also have a similar appearance. And then there's also some pneumoconioses, where because of the inhalational nature of these types of pneumoconioses, they can have a centrilobular pattern that is airways related. And then finally, there's follicular bronchiolitis, which isn't really airways related so much as the lymphatic tissue around that's around the airway. So these are proliferations of the bronchial-associated lymphatic tissues, and it's related to autoimmune disease. And then you can have vascular causes of centrilobular nodules or centrilobular only nodules, and these may be due to intravascular metastases or what's called excipient lung disease, which is when pa patients crush usually opioids to inject into their veins. And because there's binding material in this, usually talc, that material remains in the distal arterioles and can form small nodules.
Sorry to interrupt again, Dr. Duong.
Yes.
It's present on the algorithm, the beginning of the algorithm.
Okay.
Actually, I can see it. So maybe, Claude, there's a delay on your side. I can see it.
Yes, I don't really.
Yeah, I can see the centrilobular nodular side. Yeah. So Dr. Duong, you can go ahead. Yeah.
Okay. I will. I don't know what to do to make it
It's excellent. I think it's
think.
excellent. We can see everything. Yeah, it's excellent.
Okay. All right. So one pattern of airways related centrilobular disease is this tree and bud pattern or tree and bud sign. And it looks just like a tree that's in bud. There are these little nodules that branch out, and they're in little clusters. They look like little clusters of cotton balls. Sometimes they're a little more distinct than this, but they're going to be nodules in little clusters around the bronchovascular bundles, which are resemble branches on a tree. So again, this most commonly, this is due to infection, such as bacterial, either viral, bacterial, or mycobacterial infection. It also could be related to aspiration, especially if you see them in the dependent or lower lobes. It may be due to allergic bronchopulmonary aspergillosis, which is an allergic reaction to the the Aspergillus fungus and can also cause mucus impaction in the small bronchioles. You see it very commonly in patients with cystic fibrosis and also in patients with other immunodeficiency, in particular IG immunodeficiency, like combined variable immunodeficiency. And then in a very rare instances, this can be idiopathic in the case of pen bronchiolitis, which is almost exclusively seen in Japanese people. So if the nodules, the centrilobular nodules look a little bit more fuzzy, this is usually because the process has spilled out into the SNI or the unit of lung that's distal to the terminal bronchus. And as you can see here, they're larger looking nodules. They're still centrilobular. They're, even though they're very close to the subpleural, they're really centered away from the subpleural lung. And they're fairly regularly spaced apart because they're at the center of the lobule. And it looks like each of these lobules have a little fuzzy dot at the ends of them. And here's a nice case of centrilobular nodularity. Again, we have very, very fuzzy looking indistinct nodules. And if you look at the subpleural lung, there's a little black line here where there are no nodules. And it's very diffuse pattern, very pretty, very regular looking pattern of nodularity. And it looks like little fuzzy cotton balls or little plants in bloom, little flowers in bloom. And this is hypersensitivity pneumonitis or subacute hypersensitivity pneumonitis. So we're back to the algorithm here. So if you ask yourself, are these nodules centrilobular? Are they on the fissures and the pleura? No. Are they fairly regularly spaced apart or in little clusters? Yes. So the other question you should ask yourself is, are these nodules distinct or indistinct? If they're indistinct, they're more likely to be airway nodules. And if they're distinct, they're more likely to be vascular related nodules. Now, airway causes of centrilobular nodularity is far more common than vascular causes of centrilobular nodularity. So most of the time, they're going to be airway. But you have to keep in mind that some of these can be vascular in origin. So here's a side-by-side comparison of airway causes versus vascular cause of centrilobular nodularity. And this is a patient who has renal cell carcinoma and has nodules along the bronchovascular bundles, at the very tips of these bronchovascular bundles, because of metastasis that has lodged in the distal airway. And this is an airway cause of centrilobular nodularity, where you have nodules that are in clusters in a tree and bud pattern surrounding this bronchovascular bundle. And this is a case of mycobacterial infection of tuberculosis. And here, this is a little bit more difficult to see because it's very faint, and this is an older case that I had, so I didn't have a MIP image of it. But if you look carefully, there are these small, fuzzy, indistinct nodules that are seen throughout the lung. But the periphery of the lung, there's no nodule along the periphery of the lung in the subpleural or pleural lung. But these are fairly evenly spaced throughout the lung. And this is a case of respiratory bronchiolitis in a smoker. She was a difficult case because she not only did she smoke, but she had birds, and she also had a history of alpha-1 antitrypsin. So she went to biopsy, but this is, and it was found to be respiratory bronchiolitis, which is smoking related. And this case where this is a MIP image, and you can see that there are small nodules, tiny little nodules. They're a little bit more distinct, and they're again scattered everywhere except mostly in the subpleural lung. There's a lot of subpleural sparing, even though there are a few larger nodules that are out in the periphery. The pattern still remains predominantly in the centrilobular lung. And this was a patient who was an IV drug abuser using crushed up opioid tablets, and he has a excipient lung disease. So these are talc or other materials that are lodged in the distal vessels. So let's go back to our nodular pattern. So we went over the cases of centrilobular nodules, especially those that are centrilobular only nodules. So now we're going to talk about the interstitial and perilymphatic or perilymphatic pattern of nodular disease. And so for this grouping of micronodules, you'll see them on the subpleural lung or along the pleura. And the first place I tend to look for nodules when I'm looking at micronodular disease is along the pleura and the fissures. So that's and the thing that that perilymphatic nodules resemble to me is this nighttime image of the United States or of any country really. But if you'll notice, there are more lights or along the periphery of the of the United States because there are more cities along the coast where people are more likely to live, and they're in clusters. And then you have these little tendrils or highways where other cities have popped up or other little towns have popped up. And that's very similar to the interstitial pattern or perilymphatic pattern in the lung. They tend to cluster along the periphery of the lung, along the subpleural lung, but also along major cities and major thoroughfares, major bodies of water, for example, and that would be like akin to the bronchovascular structure. So you'll have along the axial interstitium, you'll have some nodularity as well. And then occasionally you'll get these little nodules along the septa that resemble these little cities along the highway here. So with the interstitial or perilymphatic pattern, you'll get small nodules that are usually sharper or have more distinct borders, and they're along in the bronchovascular distribution. They can obscure the edges of vessels, and they look like hobnails. This is a hobnailed sandal, so it looks like these little hobnails on the top on vessels and bronchi. And they will also be in the subpleural lung. Sometimes they're in the septa, and they will be centrilobular because you have the axial interstitium. So if you see that centrilobular nodularity, but also nodules along the septa and the periphery of the lung, then you should be thinking perilymphatic pattern. And there's a fairly short list of diseases that cause a perilymphatic pattern. The most common that I see is sarcoidosis, but you can also see that in silicosis or co-workers pneumoconiosis, which is almost indistinguishable. I live very close to the part of the country that had a lot of coal workers, so I got to see a lot of coal workers pneumoconiosis during my training and in my previous position. And nowadays I see more commonly because of our cancer population, lymphangitic carcinomatosis. This is lymphangitic carcinomatosis you can see in patients with lung cancer, in breast cancer. Those are the two most common cases, places where you see lymphangitic carcinomatosis, but other adenocarcinoma, such as colon cancer, can also cause a similar pattern. So if you're looking along the subpleural lung, you might see some nodularity along the subpleural lung. This is a pathology specimen actually from UCSF that has little nodules of granulomas along the subpleural lung in a patient with sarcoidosis. And here's some CTs showing that. If you run your finger along the subpleural lung here, you'll feel little lumps and bumps. Similarly, if you run your finger along the fissures, you'll see some lumps and bumps. And again, this is a patient with sarcoidosis with little nodules along the subpleural lung. And similarly, you'll see these nodules or hobnail looking nodules along the bronchovascular bundles. It looks like there's little bumps on the bronchovascular bundles. So altogether in this patient here, we see nodules along the subpleural lung. And remember, the fissures are a good place to look for that. We see nodules that are centrilobular at the ends of vessels like this. And we also see nodules that are peribronchovascular, so studding along the bronchovascular bundles. Okay, so when we're going through this algorithm, the first place again to look is that the pleura and fissures, and if there's nodules there, you ask yourself, are they randomly distributed or are they in clusters? Do they look more like a nighttime map of the United States, or are they just randomly placed throughout the lung? Okay, so I'm going to spend a little bit of time talking about sarcoidosis because it can be a very vexing disease to diagnose. It has many different appearances. So I'm going to go over sarcoidosis in detail. And as I said, sarcoidosis has that perilymphatic pattern. There's also a variant of sarcoidosis that looks like it's alveolar, but it's really not. You can have small airway obstruction or air trapping with sarcoidosis as well. So if you do an expiratory CT, you might see areas of air trapping. It has a middle and upper lobe distribution. In its more advanced stage, where you have fibrosis, you start losing the nodules. So you won't see so much of the nodules, but you'll just see the architectural distortion and the fibrosis in an upper lobe distribution. And we're seeing a lot of sarcoidosis now in the cancer population because of immunotherapy drugs, which has a sarcoid-like reaction that is an adverse reaction to the immunotherapy drugs. So there are, the stages of sarcoid are based on radiographs, on the chest radiograph. Most patients present in stage 1 where they have lymphadenopathy, so enlarged nodes in the hilum and the right paratracheal region most commonly. Stage 0, you won't see any lung abnormality, so I'm presuming that in these, when they're found in these in this stage, it's usually because they are presenting with either lymphadenopathy elsewhere or uveitis and have then gotten a diagnosis of sarcoidosis. In stage 2, you can have lymphadenopathy, but you also have some pulmonary findings. In stage 3, you start losing your lymphadenopathy, and in stage 4, you have fibrosis. So not every patient progresses all the way to fibrosis. in 25% of patients, they do go to fibrosis. I've actually seen cases of sarcoidosis where there's lymphadenopathy and it was able to resolve without progressing into these other stages. So this is a stage 1 chest radiograph of a patient with sarcoidosis, and what we here call the 1, 2, 3 sign here. We have a lumpy, bumpy, enlarged hilum, where you see lymphadenopathy in the hilum, and there is also lymphadenopathy along the right paratracheal stripe, so an enlargement of the right paratracheal stripe. So that's a stage 1 disease. In stage 2, we still have similar lymphadenopathy, right paratracheal, bilateral hilar, but we see a reticular nodular pattern to the lung. So the lung looks like looks very busy. Looks like there's these little teeny nodules everywhere. A little bit difficult to see, I know, on this radiograph on your screen, but there's little small nodules everywhere on this radiograph. And here's a CT example of stage 2, some enlarged lymph nodes here, as well as nodules that extend from the around the bronchovascular bundle. And as you notice here, if you look on this side, you'll see that there's a few nodules along the periphery. So here is one of the conundrums of sarcoidosis, which is that sometimes it looks very asymmetric. In fact, when I first saw this case, I read the chest X-ray first. I thought the patient had lung cancer and that they had a mass here with some lymphangitic spread. And the thing with sarcoidosis, sometimes it can be very asymmetric, just like it is here, where you only have a lot of involvement in one lobe and not other parts of the lung. But you can see that there is some involvement of the contralateral lung here. It's just less so than on this side. So sarcoidosis can be very asymmetric. Here's a patient in stage 3 where you start to lose some of the lymphadenopathy, and you still have all these nodules along the in the lung, and again along the bronchovascular bundles. There's a lot of nodules, and they look like they're coalescing. Here, this is what we call the galaxy sign because it looks like a galaxy, the center of which is the bronchovascular bundle, and there's all these nodules extending out from the bronchovascular bundles. So this is another case of sarcoidosis. You still see nodules along the periphery here, predominantly, though they're around the bronchovascular bundles. So this is a case of stage 4 sarcoidosis where you're seeing a lot of architectural destruction, architectural distortion in the upper lobes and fibrosis, some volume loss. Notice that the hilum are pulled upwards, but you don't see a lot of nodularity. You don't see a reticular nodular pattern out in the lung. And that is because in the stage 4, at the end stage of sarcoidosis, you may have a lot of fibrosis, but you start losing your nodularity. Maybe there are a few little lumps and bumps out here in the subpleural lung, but a lot of that nodularity actually goes away. So if you follow a patient over time, you may see nodules that start to go away. And that doesn't necessarily mean they're getting better. They're just progressing to this, they may be progressing to this more fibrotic stage of sarcoidosis. And here's an unusual case of sarcoidosis, which doesn't look like any of the other ones I showed you, or even necessarily that typical perilymphatic look. If you look at the lung periphery, there are definitely some nodules along the lung periphery, but there is this unusual reticular pattern throughout the lung, in this patient mostly in the upper lobes. And this is what we call the alveolar variant, even though it's really not alveolar. I think it's maybe because of nodularity along the smaller connect lymphatics in the septa and throughout the there is some lymphatics within the secondary lobule, but not as much. So this is a very unusual case of sarcoidosis that we sometimes see, which we call an alveolar variant of sarcoidosis, even though the origin is still not in the alveoli. So now we're going to talk about other perilymphatic diseases besides sarcoidosis. And this one looks a lot like sarcoidosis. There's nodularity along the bronchovascular bundles. There are big lymph nodes, but this patient happens to have colon cancer, and this was getting worse over time. So this is really a lymphangitic carcinomatosis from colon cancer that resembles sarcoidosis. That looks almost indistinguishable from sarcoidosis. There's some calcification here. It was a mucinous colon cancer, which sometimes has calcification. This is a very unusual case, but shows you how confusing some of these cases can be. And here is another case of a perilymphatic disease. There's just a few subpleural nodules, not a whole lot, maybe some along the septa here. Most of these nodules look like they're more centrilobular, especially these nodules right here that are spaced outside, have spaced a little bit inward from the pleural line. It looks like most of this is centrilobular, but in a few months or in several months, all these nodules coalesce together, and this patient had a history of being a stone cutter, and this was a case of silicosis due to his occupation. So very similar to sarcoidosis in that there's a lot of nodularity kind of along the bronchovascular bundles, but there tend to be more centrilobular. The silicosis patients tend to have more centrilobular nodules and less of the subpleural nodules as you see here. And here's a similar looking case of a co-worker's pneumoconiosis, which is almost indistinguishable from the silicosis case. There's nodules that are mostly centrilobular, some that are subpleural in the lung, a lot of bronchovascular nodules that coalesce into these large nodules, which is called progressive massive fibrosis. And you see there's some calcification here. So co-workers pneumoconiosis and silicosis are difficult to distinguish. In fact, I don't think radiographically you can really definitively distinguish them, although I have noticed that when in co-workers pneumoconiosis, there tends to be more calcification within the progressive massive fibrosis than in silicosis, which doesn't quite have as much calcification. So the last pattern of micronodular disease is the random pattern. Again, this is pretty straightforward, just looks like the nodules are anywhere in the along the secondary pulmonary lobule. So there are the diseases associated with a random pattern, miliary tuberculosis, fungal infection, and metastasis can, of course, cause this random pattern of micronodular disease. So even though I say it's random, it may still have a zonal predominance. It tends to be more lower lobe predominant because there's more blood flow to the lower lobe than to the upper lobes. These nodules are hematogenous in origin, so they're carried via the blood vessels, but they can still be anywhere in the lung because they don't remain in the blood vessels. And again, the differential diagnosis is infection and metastasis. So here's a case of miliary tuberculosis, lots of random nodules, and some of these nodules are a little bit larger than other ones. I think that's very commonly seen in these hematogenous patterns of nodular disease. If you look at the, oh, I've lost my mouse. There's my mouse. Okay, if you look at the subpleural lung, there may be a nodule here and there, but they just seem very random. They're just one here, one there. There's no pattern to this nodularity. Some of the nodules are a little bit larger too, which is more commonly seen in this hematogenous random distribution of micronodular disease. So let's put this all together again in this algorithm. First thing you want to do is look for at the fissures and along the pleura to see if there's any nodularity. If there are, you go down this pathway. Are the nodules random? If they're random, then it's miliary. It's one of these: miliary tuberculosis, fungal infection, or metastasis. If it's not random and more clustered along the bronchovascular bundles, centrilobular and subpleural lung, then it's perilymphatic. And then if it's not along, there are no nodules along the fissure, then it's ask yourself, is it more centrilobular, and whether the nodules are distinct or indistinct, and that can lead you to airway processes versus vascular processes. Let's see. Okay, all right, that took a little longer than I expected, but I was hoping to go over some cases, so maybe we'll do just a couple to practice. Do we have time for that?
Yes, we do. Yeah.
Okay, so here, this is a 39-year-old woman with dyspnea, and here's her CT, or her chest radiograph, and I'm going to show you her CT. Okay, and remember the algorithm, looking at the pleural nodules and subpleural lung first to see if there are any, and then ask yourself if it's clustered. Okay, so what type of micronodular pattern did you see there? Was it centrilobular, perilymphatic, or random? Trying to look at the chat.
Said perilymphatic, random, perilymphatic.
Okay. Go back. So, yeah, so there's nodules along the pleura here. There's some clusters of nodules here. There's nodules along the bronchovascular bundles. So this is a perilymphatic pattern. So what diagnosis would you think of with this patient?
Sarcoidosis, neoplastic metastasis, sarcoidosis again. Looks like the replies have slowed down now.
Okay, so this is sarcoidosis. Nodules, if you remember back from the first, the radiograph that we saw in the beginning, there's some lumpy, bumpy looking hyla, so lymphadenopathy, and then the nodules along the in the perilymphatic pattern. So this is the case of sarcoidosis. Okay, let's do one more. This woman has shortness of breath that she has acutely, but then it got worse after spending a week at her mom's house. Okay, so what type of pattern is this?
No replies yet here.
Yeah.
So centrilobular again. So 2 responses, centrilobular.
Great. So let's look at the periphery of the lung along the fissure. Are there any nodules? There's almost like a nice thin black line along the periphery of this lung. It looks very, very regular, very indistinct, okay? And very regular, very indistinct. So this is a centrilobular pattern of lung of micronodular disease. So what do we think? Is this airways or vascular in
I've got
origin?
one for airways right now.
Mhm.
Another airway.
Okay. Terrific. So yeah, this is an airway pattern of lung disease. It's very indistinct, definitely centrilobular, very regular looking. And this is another patient with subacute hypersensory pneumonitis. She had chronic shortness of breath and then went to her mom's house for a week. I guess whatever was there. Maybe she's allergic to her mom. I don't know. But she got worsening disease during the time that she spent with her mother. Okay, let's do one more. This one, I don't have a history for you. This one's a little bit more tricky. So looking at.
Yeah, I'm waiting for responses now. I'll let you know what I see.
Yeah. Maybe this one will be helpful. Looking along the fissures.
All right, Dr. Young, they're still thinking right now. So.
Okay.
Got one for perilymphatic, another for perilymphatic. One subpleural response, so 2 perilymphatics and 1 subpleural. Another perilymphatic, one for random, another perilymphatic, so mainly perilymphatic. It's a choice.
Great. Yeah, so this is mostly along the subpleural lung. Some of it's along the bronchovascular bundle here. And this patient has some pleural effusion as well. And this is a case of lymphangitic carcinomatosis in a breast cancer patient. And again, breast cancer is one of the most common places we see perilymphatic or lymphangitic carcinomatosis. Okay, I guess we'll do just one more. So what do we think about this one?
Random, centrilobular, centrilobular, centrilobular.
Okay, so this one I think without the MIPS might be a little tricky but there are a few little nodules along the fissure here, and they're different sizes. They're very discrete, and this was another random miliary pattern. This was a patient with miliary TB, but I think again that MIP would really help you. I just didn't have one for this particular case because I saved it a long time ago. We don't see miliary TB too much in in this country. So, but they're randomly distributed. If you look along the fissures, there are some nodules along the fissure, though not a lot. It just doesn't look like they're clustered in any location. All right, so should we stop there, do you think? Do people have any questions? If not, we'll continue.
Yeah, I'm looking in the chat box now with the Q&A and chat boxes. If there's any questions, I'll read them out to you, Dr. Young.
Okay. Well, I'm going to continue since we have a little time left. And if there are any questions, just let me know and I'll stop what we're doing and I'll answer them. Okay. So this was a 20-year-old college student with persistent cough for 2 months. And she was riding the bus to work every day. So what do we see here? What type of pattern is this? Are these nodules in?
Unmuting. Tree and bud,
Mm-hmm.
perilymphatic, tree and bud. So 2 tree and buds and 1 perilymphatic.
Okay. So even though they're long, they look like they're around the bronchovascular bundles, they have this tree and bud appearance. They're extending out from the bronchovascular bundles. And again, they kind of stop at, remember, look at your pleura. There's nothing really along the pleura. There's some more consolidation here, but not nodules along the pleura. There's a nice black line between these nodules and the pleural surface. Also, there's this cavity here. And does anybody have any ideas about what this could be? What the diagnosis is?
I have infectious tuberculosis, another tuberculosis. So
Yes.
overwhelming tuberculosis here.
This is definitely tuberculosis. Upper lobe cavities with tree and bud opacities. That's tuberculosis. Reactivation, most likely tuberculosis, given the upper lobe cavities. I don't see anything in the Q&A still, so I'm going to continue. Yep, so the cavity in the upper lobes, especially with the cavity, you should be considering tuberculosis. Other infections, viral infections certainly shouldn't have cavities in there, and bacterial infections as well shouldn't have cavities. So this is a patient with chronic back pain, and I'm showing you here the MIPS. This is the similar level here. This is the thin section CT, and these are the maximum intensity projections. And what are we seeing here?
All right, waiting for the responses. I'll let you know. Tree and bud.
Mm-hmm.
Tree and bud, two tree and bud responses. Micronodules. Centrilobular. So it looks like you're getting everything right now. Tree and bud, but perilymphatic, centrilobular, miliary, centrilobular.
Yes, so this is a more of a centrilobular pattern. It definitely looks like it's tree and bud. It's a little bit more distinct. They're smaller and a little more discrete than the tree and bud nodules that we saw just now with our TB patient. So this was a patient who was abusing opioids, using IV drugs, and he was, here's a closer up look here, very nicely branching nodularity. It really looks like it's coming out of little branches of a tree. Yeah, this was a case of excipient lung disease, discrete nodules, small centrilobular and discrete nodules in this patient. And you can see how difficult it was to see that on the thin section CT. It's very difficult to see those little nodules until you actually use the maximum intensity projection. So if there's anything to take away from this, is that maximum intensity projection CT, thick section CT can really help you figure out where these nodules are. Okay. Okay, well, it's about 9 o'clock, so, or my time, so I think we should stop there. Any last questions?
I'll say there's a lot of thank yous. So thank you, Dr. Yoon, for your time today. It's very informative lectures of what a lot of the comments are saying. Thank you, great talk. So mainly a lot of thank yous. Thank you, Doctor.
All
Thank
right.
you for the talk.
Well, thank you for having me.
Excellent information, images and diagrams. Thank you a lot. That's from Mexico. Thank you very much. Thank you. And I just wanted to say thank you also. Very informative talk. I do have actually a breast imaging faculty next to
Yes.
me. He actually had a question, so I'd say, hey, come on in and ask the question. So here he is, going to go into the camera here and ask the question.
Okay. Hi, my name is Dr. Agarwal, and I just had a question about when you mentioned that case with breast cancer.
Mhm.
A lot of times for metastasis, we do a CT scan test out in pelvis, but should we change our protocol to high resolution CT scan of the chest and the abdomen pelvis? Would that catch more disease?
Well, I would say that I don't know what your protocol is, but we, for oncology imaging, almost always do thin section imaging now. So we do 1 millimeters on all of our oncology imaging. So for us, there's really not a lot of difference. The only difference for our high resolution CT is that we do expiratory imaging and then occasionally prone imaging if we're looking for interstitial lung disease. So I would find out like from what what their imaging protocol is. I think the MIPS are helpful. Having the thin sections can be helpful, but I think most places are already doing fairly thin sections for it. And really, as you can see, like sometimes the MIPS are the most helpful for looking at lymphangitic carcinomatosis. So yeah, it's difficult to answer that question not knowing what their protocols are. And if they need help with that, I can certainly help them design a protocol for our oncology imaging that we use.
Thank you, Dr. Young. You're getting some more, many thank yous. One from France here, merci beaucoup. Great presentation, informative lecture. That last CT for TB, tuberculosis, approximates diagonal distribution of tuberculosis. Well done. That's the last comment. But again, thank you very much. And, to have an expert in the field to give this presentation, very much appreciated. And with such a kind of decorated background as yourself. So thank you so much.
Thank you. It was really fun. And I hope that you could understand me and I spoke slowly enough and that they didn't translate something embarrassing into French. All right.
Have a good day, everyone.
All right. Thank you.
Bye-bye.
Bye.